So, good afternoon, a very warm welcome to you all. Thank you for joining us on this rather miserable but hot and wet day in Brussels, the impact of climate change, obviously. It's good to have you with us. My name is Dharmendra Kanani. I'm the Chief Operating Officer and Chief Spokesperson for Friends of Europe, and I'm echoing at the moment for some reason. Perhaps that's the climate saying something bad to me. So I'm your moderator for this session this afternoon. This discussion comes at a very timely moment, I think, for all of us, regardless of discipline. I think all of us are, through family, friends, communities that we're aware of and connected to, are experiencing the squeeze on health and healthcare and well-being of people. There's a kind of, I suppose, in Europe in particular, an insecurity about whether the system's going to pull apart. Will it survive? Can it actually meet need? And we've all got friends and family who've got horror stories to tell, I'm sure, from various parts of Europe, where the issue of waiting, the issue of, sorry, someone's telling me that I've got something wrong with my mic.
Yeah. Just trying to do. Can you please?
Sure. Okay. I'm still echoing, but never mind. Sorry, excuse all this. We can live with the echo, don't worry. So we've all got these experiences. I suppose today is not to necessarily unpick and deconstruct the problem. We know what the problems are. We've got years of underfunding. You've got issues of staff shortages. We know that innovation has not been invested in over the years. And actually, the systems that we have in place right now are crafted almost 40, 50 years ago, if not before. In terms of the antecedents of the modern healthcare system, we know it's dated, it's not in touch, and it's actually not in tune with where we find ourselves as communities and societies, but also the modern, I suppose, experience of health and what that means for an aging population, but also for a growing younger population, everything in between. And COVID, I suppose, gave us the biggest wake-up call that enabled us to really understand, after years of complete complacency, where the cracks are and where the inequalities are, and actually opened up the cleavage of the fact that the modern healthcare system isn't fit for purpose in a broader sense, with some examples of good practice in pockets, but by no means at a national or an international level. So today we're going to be talking about innovation, enhancing innovation in terms of improving the capacity and capability of the system. What does it look like? What does it feel like? What should we do? And we hope that you're not going to be sitting on a bus of spectators and watching things go by. We want you to engage in the conversation. You're here, we have an hour of your life which you're not going to get back, so let's make the most of that time together so we can really delve into the issues that are at heart of the modern healthcare system and what do we need to do to innovate better to improve its capacity. I want to start off with Andrea, who is a well-known figure from Edward Lifesciences, Vice President there, and someone who we've kind of engaged with over the years. So it's a real pleasure to have you back, Andrea. You do amazing things in your company in terms of innovation. You've kind of created products that can, absolutely save lives, and you could do them at scale. What I want to hear from you is, what do we need to do, or how can we use innovation, or technological innovation, or innovation per se, to improve both quality and quantity? I think we lose either one or the other, but we should try and keep both when we think about innovation. Over to you.
Excellent. I'm on? I'm on? Yeah?
Yeah.
Okay, excellent. So thanks for the question. Thanks for hosting the meeting. Thanks for having me. You touch a point that is critical. I think that one of the most unintended impact of the pandemic has been validating the fragility of the organization of our healthcare system. I don't think if you close your eyes and you are back to March 2020, healthcare system that collapsed in Italy, in UK, in Germany, in France in 3 weeks, in Spain, it means that they were hyper fragile already. There's no any other reading on that. The reaction the governments are taking, apart from many nice words, resilience, rebuilding, building back better, etc., etc. They play all on classical tools. I have a shortage of doctors, I hire more doctors. I have a shortage of nurses, I hire more nurses. Sometimes even drying out healthcare systems that are fragile in other parts of the world, can be Philippines, Latin America, etc. So we keep putting Band-Aids on Band-Aids, hoping, finger crossed, maybe it works. There's not really a strategic planning. There's lots of reading, studying. What is surprising is that actually, when you look, there's a lot of technologies. And I'm talking not only obviously of what we do, but you think in the robotic, in the space of the digital, in the space of the transcatheter or minimally invasive therapies, that are not only studied, validated, available. One of the major problems today, innovation is always innovation of processes and innovation technological. We have the technological innovation, but we don't have the processes that enable to adopt and expand and measure the results. Oncoming, we had with the European Commission and the Member States on June 14, the first meeting of the stakeholders of the medical, of the HTA regulation, all the value assessment, we are still back the spectacles of 20 years ago. Clinical trial design, Markov model, economics, etc. No one today is still talking about efficiency gain. If an innovation can bring an efficiency gain, how I can measure that? How I can deliver more and better healthcare? How I can reset the long waiting list that are materialized? I think there are also some ethical demand, just to say, in UK, a study made by the University of Liverpool, a group of biomedical engineers from the University of Liverpool, that's on aortic stenosis. People already diagnosed between the first and the second wave, there were more than 2,000 deaths because they didn't get the hospital in time. So it's not that they die because they didn't know that they had the disease, but they were diagnosed and they were in a long waiting list. So these cases, and I'm quoting because it's close to my heart in terms that is my daily job, looking at that type of very specific data, but when you look, is enormous. OECD already in 2017 told us that 23–24% of hospital spending was wasted. No one did anything on that. No one looked at this organization, allowed the technology can allow to redesign the way is healthcare distributed. So I think that when we talk about efficiency gain in the system, when we talk about creating conditions that are less stressful for doctors, physicians, surgeons, operators, healthcare workers, we start to create a positive, a virtuous circle in the system. We inject that. I always make an example, Dharmendra, maybe because I'm getting close to the holidays, so I think my own country. You can have here in Belgium the best, the most fabulous bicycles, the most technological innovative. But trust me, if you put in the middle of the traffic of Rome, my own town, you don't get the best performances. It will remain stuck somewhere. And this is the challenge that innovators in technologies are living today. You bring the best technologies, is measured with the spectacles of 20 years ago, but most of the processes are not at the level to adopt, to exploit the benefit of those technologies. So I think this is really the challenge that we do have to answer to your question, how can give better healthcare, having a patient with full heart, open heart surgery, one patient 6 hours, 2 weeks in the hospital, or with the transcatheter intervention, 1 hour, 2 days out at home, working, and maybe if he's in Belgium, pedaling on his bicycles. You see, these are the impact and the value that still we have difficult to measure, to understand, to share, and to execute and implement.
So is it, so there's something in what you're saying is about mindset, and there's something about the fact that the ecology of the organization of the system prevents itself from employing innovation in a meaningful way, in a scalable way. Are those the two issues?
I think it's a matter of processes. When I talk about processes, it's the way as healthcare is organized and the way as healthcare is funded.
Okay.
It's very simple. You can demonstrate in a given country, I can use just to France, for instance. You can, if you are in an innovative product list, you can demonstrate that you generate efficiency, an efficiency gain in economic and pecuniary terms, but they would say, you know, it's not me, it's the other department. I'm looking only at this list. And you say, okay, but, you know, I have, this is the way of reading innovation 20 years ago. Now you have impact that goes far beyond the classical efficacy, effectiveness, safety, etc. There are other values. And that's really the transformation that is needed. Most probably easy to say, but if you never start, you know, Lao Tse, a long walk starts by moving one foot. If we never start to enter in that direction, we risk automatically to continue a discussion, but we leave patient outside the system, waiting list, patient dying, but not because they have to die, but simply because they are treated too late. Or even if they get the hospital in time, they get in such a dramatic condition that then became much more a burden to treat them in economic and in physical and in clinical terms.
Okay, great. Thank you very much. Francis, I was going to come to you, but I'm not, actually. Because I think let's flip it and go straight to the Parliament. And, you know, we have the MEP here. Thank you for joining us. Given what we've just heard, because Francis, I know I was going to ask you, but I want you to talk about your experience in the system. But let's go straight to the policymaker and the accountable, I suppose, politician in this game about what kind of systems are you putting in place, or is the EU thinking of putting in place to, I suppose, build innovation into the system of healthcare?
Thank you. Thank you very much. First, thank you for giving me the floor now, because I will have to leave at 1:30 because we have a very hectic schedule today in the Parliament. But yes, so what you're saying, so first, the typical mantra is that organization of healthcare systems, waiting lists, hospitals, funding, pricing, etc., is on the member states, right? It's primarily a national competence. So we cannot really legislate and legally harmonize and unify how this functions. So that's obviously the first problem. And a lot of these inefficiencies stem within the healthcare system itself. Within ministries of health, health insurance funds, hospitals, etc., which are not really, in many member states, controlled how they spend their money, etc. I mean, so these are all things that we cannot really do a lot about, unfortunately. And member states, whenever we try to do something, member states block it. Take, for instance, the health technology assessment regulation. So the whole idea of that was to instead of having 27 HTAs, to have one which substitutes them. But what we got in the end, because of the Council, is that we got the 28th HTA in addition to the 27 already existing ones. And this is obviously a problem. I think that this HTA regulation was actually a missed opportunity to try to unify at least partly this on European level, and maybe also to include some efficiencies and cost effectiveness analysis into this. However, since the result is as it is, what we are left with is the pharma package, right? So that's the big topic that's being discussed now. But pharma package in itself is pretty limited, because what EMEA is doing, and we are speaking here about the procedures for authorization of medicines, is about safety primarily, right? But the actual financial aspects and efficiencies in that sense, unfortunately, is something which is done then on the level of the member states with pricing and reimbursement. So I think so these are the problems. So what I think we should do when we speak about what we can do if we want to at least partly also contribute to stimulating innovation on European level, because there are some things that we can do. It's not only things we cannot do. Okay, so first about pharma legislation. So first we have the substantive part, that's about the incentives. And that's the big discussion. That will be the most controversial discussion, obviously. I think on that, the modulation is a good thing, that we really stimulate the innovation into things which are really necessary, where we really need to create added value, like, for instance, medicines for rare diseases, really innovative new medicines, etc. So I think that this is, as an approach, is a good thing. Of course, on the other hand, we should make sure that we do not make the system of incentives uncertain, in a sense that whether you get incentive or not depends on somebody else. For instance, on pricing and reimbursement decisions which are out of your control. So I think that's one important thing. The second thing, what is important is the procedural part. And I think that I always say, if we were able to cut down the time for approving vaccines for COVID, if we were able to take out certain parts of the administrative procedure in front of EMEA for that, why can't we do it for the rest of the things? Because if you're saying that simplifying and fastening the whole procedure did not jeopardize the evaluation of safety, then why not doing this also for other medicines as well? Because if these parts of the procedure which were cut out for COVID-19 vaccines were unnecessary then, they're still unnecessary now. So I think on that we have a lot of possibilities to make things much faster, because when compare what Europe is doing with the US, you see that we are really lagging behind in terms of this whole procedure of evaluation. Also, I personally think that once EMEA has made its decision, has conducted the assessment, there is no need for the Commission to be making the final decision. EMEA should be doing this in itself. Of course, I know that it's not realistic that we remove Commission from the procedure completely, but I think that what the Commission is doing, and that's essentially rubber stamping what the EMEA has done, should be done in 2 or 3 days. We should wait for 30 or 40 or whatever days for that. So I think also that this process for approval can be much faster than it is now. So that's about the pharma package. Apart from the pharma package, I think when we speak about pricing and reimbursement, which is primarily national competence, but still we have a legal tool which can make these national processes much faster and more transparent, and that's the so-called Transparency Directive. Unfortunately, this is one of the pieces of legislation which has never been amended in 34 years. Why? Again, because of the opposition of the member states. Because when you look at the pricing and reimbursement procedures of making national decisions, we see that there are big variations. In my country, for instance, the legal framework is completely vague. So it just says that there is some kind of a committee between the health insurance fund which makes these decisions. And some very broadly defined criteria are put there, but you don't see the deadlines, you don't see the actual procedure, how it's regulated, right to remedies, etc. So you don't have nothing like that in the legislation. So trying to harmonize at least partly that part, I think it's legally possible under the current division of competences, and I think that this will definitely make it easier, the whole system, and more transparent and even more unified. Again, the problem is member states don't want that, at least the big member states. And of course, in general, I think when you speak about innovation, we have the problem of too much bureaucracy in general, too much administration, 27 different national systems, and not having the real single market in place yet. Single market is not a very popular thing now to discuss. It's not sexy, let's say, but I think that if you are a producer, if you want to put innovation in the market, that all of these different national systems, this jungle of regulation, the new regulation that is now coming up from the Commission because of the Green Deal, is definitely not helping things. So I think that we in Europe, if we want to be more competitive, apart from the incentives, faster procedures, more transparent pricing and reimbursement decisions, we also have to think about all of this regulation and all of these additional administrative burdens that we are putting on, not just on the pharma industry and the producers of medical devices, but also on all other companies in Europe. Because I think essentially that in terms of competitiveness, we are shooting ourselves in the foot. So with all of these new obligations which are coming up in EU legislation, we are just making it harder and harder for anybody to go and invest into Europe. So I think definitely we have to do something about this. Of course, Green Deal is important. Environmental protection is important. But if we destroy our industry, in the end, what will happen? You will shift the production to China, where the environmental standards will always be much lower, and you'll get more CO2 emissions than you have now. So again, the end result will be counterproductive. So I think that there are many structural problems that we have to tackle in Europe, but definitely I think that legislation needs to be much more business-oriented, much more turned towards competitiveness, and really be more business-friendly in general.
Thank you for that. You paint a very bleak picture. It's very depressing what you've just said.
I'm saying what we should do. I said that what
but
we
you
should
also told us it does, when I listen to you, I think to myself, what's the point of having a public health committee in Parliament? You know, really, what is the point? And I mean that in the most respectful way. It feels like window dressing, because everything you want to think about and do is stuck at the member state level. And if you want to be innovative, it gets vetoed by the council because of the absence of unanimity and protectionism of domestic markets, in effect, actually. So, you know, what hope is there for... Europe is meant to be a project of values, and where one would think that Europe can add value is to perhaps modulate, create a proxy healthcare system to say this is how it could run, for example, and therefore you show by doing, not necessarily put it into place. For example, the amount of money that's being wasted on databases. Basically CRM systems in 27 countries. And in some countries, they're multiple. And basically, the only person that's actually winning are the private sector, because it's great. Having multiple systems for data only makes the private sector more profit and makes actually the health system less efficient and more costly because they're not operating. So I suppose my question to you is, forget health competence at the EU level, because I don't feel that we're ever going to get there. People talk about it. But what would you, we've got a new mandate coming. In this current mandate, it experienced the biggest health crisis in the planet. And we, as a world, experienced something quite significant that created a tremor inside all of us. When you're looking ahead, what will your committee say to the new mandate? What would you want from them in the new policy book for 2024?
Okay, so there are 5 or 6 questions there, but I'll try to be succinct. So first, on the committee, I mean, the problem with committee is that there was big opposition to really have a fully fledged real health committee. So this is because, for instance, I'll be open. The chair of ENVI didn't want to lose his power, so he didn't want to transfer the legislative competence to the new subcommittee. Of course, we hope that this will change after the elections. The EPP will strongly push for that, and this is one of the most important things and issues for my political group. So we want health to really have a self-standing legislative committee so that we put health much more on the priorities list of the EU. Okay. Because on the other hand, I wouldn't be so bleak. So if you look at what healthcare was before the pandemic, before the Europe's beating cancer plan, it was completely marginal in Brussels. So it was not really a topic that was very popular to talk about, etc. But now after COVID and Europe's beating cancer plan and all that, healthcare has really become one of the focuses of the institutions, which is a good thing. And also the COVID has shown us that when there is a political way to resolve some issue which member states cannot resolve themselves, we can find a way. Yeah. So we have all of this new legislation on cross-border health threats, the new mandate for the ECDC and them, etc. So there is a way. And legally, I mean, we always, when we want to actually have something done, we always use the internal market legal basis, which does not require unanimity but qualified majority. So legally we can do it if we find a common understanding, but at least with the majority of the member states, that something needs to be done. So I think, and for instance, what I mentioned about removing the regulatory obstacles, that's not, I would say, the council fault, but the fault of the one who is proposing all of this new legislation, right? And that's not the council. So I think that, I think on that issue, we can really, it's not just that nothing can be done and that member states block everything. I think it's the question of having a bit more differently defined political priorities, not just on the council level, but also on the level of the Commission as well. Yes, so I think what is important is to keep the momentum. I think it's important that we keep discussions like this, that we strengthen this special to have a really special health committee in the next mandates, that it's not shared with environment, because environment has become such a big topic that you cannot have such 2 big topics in the same committee. And in that sense, I think that a lot of things can be done. Mm-hmm. On the digital, yes, you know that we are currently negotiating the European health data space. Mm-hmm. So that's precisely the legal instruments which should resolve the problem of having these different national, non-interoperable digital systems, etc., etc. And I think the proposal, the idea of the proposal is pretty good. The Commission's proposal. I personally, as the rapporteur for this, endorse it. I think that we can make some adjustments and improvements, but I think the whole idea of having this kind of European health data space, we should make it mandatory to share data between the member states,
Indeed.
also with healthcare professionals, but also not just for primary use, for healthcare provision, but also for research, innovation, etc., is very important. On that, of course, we have some contentious issues as well. I think the most contentious issues always is IP rights, right? You know, EBP's position is that we think that IP rights protection is crucial if we want to have innovation. So this is our position, but not everybody shares it in the parliament, to put it mildly. And the second point is about the role of the patients. So whether their data should be used for research and innovation, whether this should be a consent-based system, opt-in or opt-out, etc. So this is the big discussion. So our position is for secondary use. So for patients to share their data for secondary use like research and innovation, that opt-in is the wrong way to go, because opt-in means that you need to get proactively every patient to sign up for that. We don't think that's realistic. We would just not get enough data if we want to do that, and this data that we do get would not be representative. So this is why I went for an opt-out. So the whole idea of the opt-out is that those who don't want to be part of the system, who don't want their data to be shared for this purposes like research, innovation, policy making, etc., can decide not to, but we believe that with an opt-out we'll get enough data that it can be useful in the end, that it can actually create results.
Okay, I'm conscious of time and you're going to have to go. So, and it's unfortunate. Those of you who have any questions to Tomislav, you can note them or send them to us, and we'll, because I know you need to go. But so there's two things that are going to affect your mandate, but also politicians across the business, that we know over 80% of citizens think that the healthcare system in Europe needs radical reform, and over 90% are happy to share their data. So, you know, we've got two issues there of political, I suppose, willingness, a willingness of the electorate to actually see change. So, I mean, I think that's an important point to consider. Thank you for joining us, but I know because of the time that you need to leave. But I'm going to move on and go back to Francis, actually, if I may. Francis, let's go to the coalface. Thank you very much, and good luck. You are the president of the Association of Belgian Hospitals. You also relate to hospitals across other countries. Give us your take on what the challenges that are currently being experienced. We've heard of horror stories, but you literally are at the coalface. And what do we do about using innovation or technological innovation to improve the workforce crisis that we've got currently?
Yeah, thank you for the question. Yeah. Maybe just to respond to the question, I will take the crisis of healthcare workforces through three different angles, from a broad to a very narrow perspective. First, and probably a lot of you know this type of figures already, but we clearly today lack many of our staff in the hospital. If you take Belgium, for example, today around 10,000 nurses are missing in hospitals, which is around 5 to 10% of the staff, which has a consequence. So many beds are closed, and you start to have waiting times also in Belgium. Belgium has historically a system where the waiting time were very low, a very accessible system of healthcare, and it starts to be less and less true. That was the very broad perspective. If you think about the hospital I manage today, what has been a consequence, we clearly and aggressively recruit abroad. Andrea gave this example from countries outside Europe, but it's also inside Europe. So we have many staff today who came from different countries in Europe, and we know, because there is clearly an ethical question behind this type of recruitment, we know that we are clearly putting pressure on these countries because we are recruiting maybe not all their staff, but part of their staff, and it's not so easy to replace them. A second part on the hospital side is that we clearly see an increase of temporary, or what we call the interim staff in the hospital. It has also consequences, both in terms of quality or security for the patients, because we have now between 10 and 20% of the staff which does not know very well the hospital, came for a few nights or few days to work and then will go to another hospital. Again, in terms of quality, it's not good. And in terms of efficiency for the system, this staff is clearly much more paid than the others, which put, again, pressure on the hospital. But also in terms of organization, I mean, it's a nightmare to have staff that suddenly say, okay, I can work tomorrow and not anymore the day after. And that's, I think, the reality for a lot of hospitals today in Europe. And a third dimension is a very narrow one, but I think it's interesting and maybe give you a good perspective on this crisis. I was yesterday with the nursing school close to our hospital. For the next year, they have 5 new students. Only 5 students for the new year. In comparison, they had between 50 and 60 students the year before.
Wow.
I would not say it will be like that for every school, but I think it gives clearly a sign for the years to come. I don't think it's a crisis that will stop. I mean, COVID crisis has been probably a kind of revelator of this crisis, but it will not stop. I think we are for a generation of issue about lack of staff. I think that was for the context. Maybe to respond on the question for how innovation can help solving this issue, I would position my response in 2 parts. The first one on the studies, on education. Clearly today there is an issue about education for healthcare professionals. We have had the tendency to increase the standards of quality and standards of education for a lot of healthcare professionals, which in a way was good. And in terms of quality, we want to have staff with a very high level of quality. But in terms of the reality on the ground, I think it was clearly maybe not the right decision to take, because now we have very qualified healthcare professionals for a lot of tasks, and they are not satisfied with it, especially in hospitalization parts of the hospital. I mean, they are doing clearly basic stuff, basic tasks. They have studied 4 or 5 years almost at university. I mean, there are clearly a mismatch between studies and the role they have to play in hospital. A second part is about digitalization and AI. Clearly, there are a lot of solutions that are coming to the hospital. I think we discussed already about the legislative issues and how we can, and regulatory issues for inside the healthcare system. There is also a question about acceptance of the staff. I will give you two examples. If you think about measuring the vital signs of the patient, so oxygen, blood pressure, temperature, this is probably between 20 and 30% of the time for a nursing staff in hospitalization. Clearly, again, basic tasks, not very intellectual tasks. Technology will probably help, but we need acceptance for that, because it will reduce probably the number of staff per bed in a lot of countries, and we need obviously to have confidence, and especially the staff needs to have confidence in the system. And today there are a lot of promises about technology, but if you take these concrete examples of measuring the vital signs of the patient, I don't see a lot of hospitals in Europe that really use this technology in a broad way inside the hospital. So that's one example. The other example I wanted to give is about AI and imaging. If you think about, for example, the breast cancer screening, this is clearly a very common medical activity. Today it's still very manual, so we are taking the image, and then again a physician needs to take between 5 and 10 minutes to look after the image to see if there is something. We know that there are very good AI tools already that can clearly identify if the image has something wrong. Some countries have moved a bit ahead and tried to use this, but there is clearly a lack of acceptance from the physician side. I mean, a lot of physicians today don't want to use this type of tools, either because technology has not been a huge part of their studies, but also clearly there is some group pressure also from the healthcare professionals themselves about not bringing this technology into life in hospitals. So again, there is regulatory pricing issues, but there is also something about adoption of acceptance of the staff.
Do you think that's, is it fear or age or both in terms of adoption of new tech? Because, I mean, when you think about it, COVID, I'm sure all of you suddenly acquired the blood measuring thing, the blood pressure thing. My home's littered with it because, you know, family, all the rest of it. We all suddenly became doctors in terms of looking at and testing everything. So we also know people wear these watches now where everything is monitored. And, you know, you can transfer that data straight over to a system in the healthcare system, and you cut out that 20% to a certain extent. But the imaging thing is more substantial because we know, actually, because of the quantum computing behind AI in imaging, the accuracy rate is nearly 99%, if not more. I mean, it's nearly, you know, 100%. So is it about age or fear, or is it both?
I think at individual level is probably age or fear, but if you start to bring this topic to at group level, like the radiologists, I don't think it's not anymore a question of individual fear, of age, or lack of knowledge of technology. It's also clearly a question about what will be the tasks, the responsibilities of radiologists in the next 10, 15, 20 years, because if you remove all these parts, you probably remove between 10, 20, 30% of the radiological business in this specific industry. So you need to bring the radiologist into this debate. What will be the added value in the system?
Yeah.
For example, that was a very good example. One company has developed a system where they just classify the image between red, orange, and green. If it's green, basically the physician does not need to look at the image. If it's orange, maybe give a look. If it's red, clearly it should take 10, 20 minutes to look at the image. This is not because the AI system could not directly go to the diagnosis. It's just an acceptance way to say to the physician, okay, now we have just classified the image, but you still need to look at the image. I think this is probably a way to bring the staff into and to make them acceptance about the technology.
Absolutely. I suppose innovation is the key thing here, but I suppose at the heart of this is that, you know, if we don't do this, radiologists and others, it will be done to them. You know, the technology will have a wave through. I mean, most of you, I'm not sure you're aware, currently robots are being used in theatre, in operations. Recently, I a personal level experience, a family member who basically had to have a routine bit of surgery, and the surgeon said, it'll just be me and the robot. Are you okay with that? There's no one else in the room. And it was done within quick time. And actually, what happened was they had two procedures. The one done with the robot was fine. The one that was done manually suffered a little bit because of the lack of precision, and it's but what robots can do. But my sense is the wave will hit us before we know it, and there's a sense that how do you get people like you, because there are many like you in Europe, to, I suppose, stand up and shake the can at the EU level and say, you know, enough is enough. We need to be thinking about this differently. But I'll come back to you on that point in a moment, because I want to go to Natasha, who's been very, very patient. Thank you for joining us, Natasha, and being patient listening to this debate. Good to have you with us. You have, obviously, as you are emblazoned behind you, the World Health Organization. You know about country policies and systems, healthcare systems. Given what we've gone through, you know, you've been as an organization at the forefront of both forecasting, providing foresight, and actually, you know, assessing healthcare and health systems across the world. What do you think, in terms of the lessons we need to take account of, given what we've been through in COVID, what lessons do we need to account of in terms of introducing innovation in the healthcare system?
Thank you very much, and I have been listening quite attentively. Can you hear me well, or is there an echo?
We can hear you very well.
Okay, very good. So basically, I think there were a lot of innovations that took place during the COVID pandemic. And for example, we saw this push for the take-up of digital services. But what we see is that after the pandemic at its height was sort of brought under control, we found that some health systems were seeking to go back to the past instead of finding a way to move forward, capitalizing on some of these innovations that took place, if you wish, under duress or under force majeure. What I believe is that health systems in the European region are facing some really important pressures. I would say last winter, unprecedented pressures. these were not entirely because of the COVID pandemic, and it would be naive to think that it was because of the COVID pandemic. These were deep-seated issues that had emerged over the past 2 decades. Let's not forget austerity.
Yeah.
Let's not forget the cutbacks on employment of health workers. Let's not forget also the lack of investment in infrastructure, with a lot of decaying infrastructure that could not withstand then the onslaught of the COVID pandemic. But actually what we saw was that many hospitals, primary care centers adopted and adapted quite rapidly during the pandemic when it came to infrastructure, when it came to creating beds, when it came to finding ventilators. What was the bottleneck? They couldn't find the workforce. And this is the major issue that all our healthcare systems across the 53 countries in our region are facing. What needs to be done, and what needs to be the innovation? Well, the first thing that we need to do is we need to find ways to retain the health workers who are leaving. And this happens at both ends of the career trajectory. We are seeing workers taking early retirement because they are exhausted, because it doesn't pay for them to hang around any longer. But we are also seeing young workers who, after a short spell in the healthcare system, are not willing to continue to work in the system when they compare their quality of life with other peers who work in other professional areas. Because as organizations, we have not innovated enough. But you're asking about innovation, about transformation. One of the things that really irks me is that we expect systems to transform themselves. Systems do not transform themselves. Systems do not digitalize themselves. Maybe in future, when AI takes over, we'll get to that stage. But at the moment, it's people who need to transform systems. And who are the people who need to transform systems? It's the health workers and it's the patients. So what we are saying as WHO is, if we want our healthcare systems in the European region to survive and to thrive, and if we really want to make sure that the values that we cherish so much in Europe, the values of solidarity, of equity, of universal health coverage, continue to exist and are improved rather than what we're seeing at the moment, which is a regression, which of course always hits those at the periphery, at the margins, children, pregnant women, people from minority groups, older persons, the West. We need to engage healthcare workers and patients to transform the health systems. But in order to do so, we need to trust them, and they need to trust that the system will allow them to bring about these changes. And of course, we've heard a lot about digital. And we will be organizing a second digital health symposium in the first week of September in Porto, which will be organized in a different way, because it is not digital for the sake of digital. At the moment, many countries across our region are investing huge amounts of money, sometimes into a black hole. A speaker earlier talked about waste. Waste is investment that is not smart. Waste is when we put millions into digital technologies and solutions which haven't been thought about carefully, and where we don't accompany that with digital literacy for our health workforce. Do you know that just over half the countries across the European region, from preliminary findings of a survey that will be published later this year, have in place formal programs that recognize that digital training needs to be part of the core curriculum of health professionals? Do we realize that when we talk about health systems, we're not talking about banking, travel, or retail, where the young, articulated, and educated are the super consumers, but our super consumers in healthcare are the older persons, are the people at the bottom end, of the socioeconomic groups? Do we have programs that target them, that empower them, that equip them, that make them feel confident? Let's come back to the health workforce. I believe there was an earlier question that asked, why don't people take up digitalization? Of course, there is an argument around the political economy. Are people incentivized to do so, or is there a fear that digital is going to take over their jobs? Not really. We're facing shortages everywhere, acute shortages, but what are the real reasons? Let's look at the configuration of the health workforce. The health workforce increasingly in the European region is made up of women, aging women and aging men. Who develops the tools and solutions for the workforce to use? Increasingly in the digital sector, young men. Can you see what I'm getting at? We have the supply side who are developing the tools and the solutions to be used by workers and by patients who are entirely different. This is one gap that we absolutely must bridge. But secondly, we also need to believe and trust. We talk a lot about skill mix, but when I hear skill mix, one of the things that I fear is that I'm hearing task dumping, for example. I don't want to do this. I try to find somebody else who's paid less than I am to do it. This, of course, creates a backlash. What do we want to do? We want to empower nurses, midwives, and allied healthcare professionals to be able to take up the space that they can. But we also want to empower patients, people with chronic diseases who know so much about their own care, to be able to do more for themselves because they know and they are able to do so. And it's in that way that we start to address the organizational models of care and the shortages of health workers. And of course, we also want to talk about transfer from what people can do to what technology can do, without forgetting that what we want to transfer are those administrative, bureaucratic tasks that sap the energy from the health workers. And we want them to spend the time doing what they have studied and trained to do, caring, doing the complex interventions, talking to people, doing things AI and robots cannot do. And one final point, if I may. We've heard a lot of talk about hospitals, and indeed we had a meeting in the beginning of June in Azerbaijan focusing on the eastern part of our region, where investment is taking place in renewing hospital infrastructure, and we want to make sure that we develop and design hospitals that are fit for purpose, fit for the future. But I haven't heard a lot about primary healthcare, about rural health settings, and this is what all the ministers are coming and talking to us about. They are saying where we are stuck is providing healthcare outside hospitals. We don't find the workforce in primary healthcare. We can't provide healthcare services to rural populations. How can the EU, for example, link its rural development strategies with healthcare and health systems? So the two key words for our Tallinn Health Systems meeting, which will take place at the end of the year, it's the 4th edition. We celebrate the 15th anniversary of the Tallinn Charter, which brings together health systems, and wealth, prosperity, if you wish, are trust and transformation. And the first speaker talked about the virtuous cycle. We believe that many systems in many countries are broken. And to start to heal them, we need to build this virtuous circle of placing trust at the heart between the patients, the professionals, and the funders, creating a virtuous circle. And this in itself will enable transformation to take place in a safe environment where people feel that they are empowered, that they have the agency, that they are the protagonists, changing their systems.
Natasha, I let you carry on only because it was so passionate. It was great to have that, but it was so informed and insightful. And it's great to have someone in your position, in the institution you're in, to be able to provide some really very powerful messages about what the blockages are, what we need to be thinking about. And I suppose the one question, not for you to answer now, but I would love you to think about it in the last 2 minutes that I will have at the end, is that if, heaven forbid, we have a pandemic in the next month, what would be your assessment of the healthcare system's capacity to survive another pandemic? So I'll come back to you in that in a moment, because I want to go to, and thank you, it was really very helpful. And actually you need to connect up with Andrea from Edward Lifesciences. I think you need him at the heart of your system change as a kind of a person that has a large company but tries to think about it in the way that he just expressed it. But I love your idea about people-powered change, using those at the bottom end of the system. And there's nothing like a carer or a patient that actually can see the faults in the system, because they walk into a hospital and can see what's wrong. So it's a very insightful point. I want to move to you, Eleni. You're in the engineering, as we say here, Alliance for Medical, Biological Engineering and Science. We've had a lot of conversation here about innovation. From your perspective, how can we move this forward in terms of the kind of assessments you do for technological advancement, and perhaps think about what's the blockage from your perspective in terms of moving this forward?
Okay. Can
You're
you
on?
hear
Yeah,
me? Yes,
absolutely.
I'm on. Okay, thank you. Thank you very much. Well, technologically speaking, we now have evidence that, for example, telemedicine can improve things. Very recently, there was a publication that looked into more than 2,000 studies that evaluated telemedicine programs in Europe alone. And the report includes, among other things, that telemedicine has proven to reduce time to respond, has proven capable to reduce hospitalizations and unwanted referrals to specialists, for example. However, today's technology can use advancements both in bioengineering and informatics, like artificial intelligence, to take all these things a step further. We are now creating tools that are smart, active components that can be used by the patient to help them stay out of the hospital and to help them care for themselves, mostly autonomously, at a great extent autonomously, without real human intervention, or with human intervention, an expert intervention when needed. So just to give you an example, in the area of cardiovascular disease, for example, which is a great burden, we started, actually first telemedicine demonstration was by transmitting an electrocardiogram over the phone back in 1906. Mm-hmm. So back then, cardiovascular disease was diagnosed by listening to the sounds of the heart via an otoscope, and treatment was more or less admitting a patient into a spa, if you believe me. So in the last 100 years, biomedical engineering and informatics have completely changed cardiovascular medicine, actually created cardiovascular medicine. Start with electrocardiograms, X-ray, chest X-rays, later on ultrasound and radioisotope imaging, and then for treatment, cardiac catheters, stents, you know much better about that, you produce a lot of that. And even artificial heart. Now we are at the verge of bringing a new paradigm shift in this area. That was a very good, great toolbox for the professional to work with. Mm-hmm. Now technology is developing new components that can actually work on their own, at least most of the time. Just to give you some examples that you probably know a lot, very well, we have implantable defibrillators and implantable pacemakers. We have all these wearables that can actually predict cardiac episodes. And now we are innovating even in the areas of imaging, whereby we have produced ultrasound scanners that are very low cost, that are portable, and you can actually wear them. There was very recently the announcement of a skin patch of an ultrasound device. So you can have continuous monitoring based on AI, and you can have autonomous calculation of a lot of diagnostic indices. So that actually brings, technologically speaking, that actually brings us in a new era where we can empower the patients to care for themselves, mostly autonomously and mostly outside the healthcare enterprise, and leave the experts to care for all these situations, as Natasha said, where they were trained to do. So to make all this work, though, we need to put in place very rigorous health assessment, health technology assessment procedures. And actually, the way to use health technology is, of course, to try and create cost-effectiveness reports about every new technology, and also have the social dimension of introducing a new technology. But I would say more than that, we should use these evaluations to try and integrate efficiently technology into everyday clinical protocols. That's what it's missing. We create technology and then we leave it alone. We have to integrate that into the existing clinical protocol, the routine clinical protocol. And doing that, we have to give feedback to update any existing regulations, legal frameworks, insurance frameworks. It's a whole lot of things that we need to update after the assessment we do. And last but not least, we need to create training, as Natasha said, and also introduce change management techniques, very well known from the management area, both for the experts and the patients. So you can't expect innovation alone to solve the problem. You need to work with it and introduce it in the proper way. So I would definitely agree, more than agree with Natasha.
Okay. Eleni, you're an alliance, right? So you have a view of, and I'll bring you guys in. I'm just going to say, if I can crave your indulgence for extra time to run over to, and then go just 10 minutes or so. And I hope that's okay with you guys. You have that overview. Can you point to any country or region or city where you see this happening well? Is there good practice that you could kind of bring out and share?
Well,
Yes, on.
okay. There are a lot of islands, a lot of different introductions of new technology. And when I say islands, I mean in different expertise, different medical expertise, different diseases, different problems, sometimes in different areas as well. But I wouldn't say that we have a perfect, holistic, successful experiment yet.
What a pity.
So we have good examples of a lot of digitization, for example, in Northern Europe. We have some specific examples in countries like us, in Greece, where we have many islands and we need to support people remotely. But I wouldn't say that these examples are very well introduced properly into protocols, covered, for example, by healthcare insurance systems, accounted for in terms of legal frameworks, I mean, who's responsible if something goes wrong, and so on. So there's a lot of work needed to be done to integrate them in the proper way.
It's a shame the politicians are not here because, you know, in terms of Europe adding value, they could literally prototype some of this. Like, you know, like the big missions they've got in oceans and the moonshots, they could actually fund flagships in, let's say, 5 states and say, trial this. and see whether you can create an integrated new model of healthcare. Could be possible, right? It's totally possible.
Yeah. Sorry, I would go the other way around as well. Every time you introduce a new regulation or you have a new view, political view, it would be nice if you try to test it first and then finalize it. Because sometimes we find bottlenecks in front of us while things created in a political level, they cannot be really implemented in the best way. So you need to have a continuous, very quick, agile feedback loop, which is not there yet, I think.
I wonder what a Minister of Health that might be sitting at the back of the room thinking and probably shaking his head, thinking these people don't have a clue of what's happening on my doorstep, because of the pressure in the system. And it's about how do you get through that white noise. I didn't mean that in a racial tone, in a racial sense. But how do you get through past that sense of chaos, needing to be politically agile and solve the problem? I need to make sure I reduce the numbers. And you can't hear, this conversation is just not heard by the politician. But I'll come back to you. Over to you. Any questions?
I'm afraid I'm going to have to jump off. Thank you so much for having me, but I've got another meeting I've got to connect to at 2. And,
okay.
Thanks. Great
But don't
debate.
forget my question, Natasha, whether you think the current
I can answer that right away.
Go on.
Everybody's asking the same question.
Yes.
And I don't think from what we are seeing, whilst the lessons have been learned, where you still have, at least as a basis, health workforce shortages, you are not going to start off on a very strong footing. So that's the one gap that needs to be plugged.
Great. Thank you very much. Thank you. Okay. So, here's your chance. Please do introduce yourself.
Thank you. My name is Oliver Bezatza. I'm the CEO of MedTech Europe. Thanks for organizing a great session. It may be the summer weather, but I'm feeling actually tentatively optimistic.
Ooh.
Because it's not so long ago, during COVID, we all were talking about how nothing helps focus minds and find solutions like a good crisis. And if I've heard you well, this thing is turning into the mother of all crises, not just in Europe, but healthcare systems around the world. Yes, there are questions about whether the innovation is accepted by users. Yes, there are questions about training. Yes, there are questions about reimbursement and uptake. But if it's truly the crisis it's made out to be, and I think it is, we're going to have to, one way or another, try those solutions which are out there. How many of us, before COVID, were systematically seeing our doctors via this phone remote option that was created very, very quickly? I hadn't, maybe some of you had, but it's now part of my regular patient experience. It hasn't replaced the in-person experience, but I have doctors where all but one of my consultations per year are happening over the phone now. I love it, the doctors love it. It continued despite the fact that WHO declared the pandemic over. And the only thing I'm asking myself is, why the heck didn't we do this earlier? Why did it take a historic pandemic for us to apply the technological solutions which were perfectly available all this time? So we like to say humans are innovative. I think humans are particularly innovative when their back is to the wall. And if we've got no other choice but be forced into actually trying these situations, it's going to happen. And if we don't in Europe do it first, other healthcare systems in other parts of the world will do it. Either because they're more entrepreneurial or because we will have forced their hand by recruiting their healthcare workers. And so for me, it's not a question of if, it's a question of when. And do we want to, as Europeans, proactively make this move and try and exploit the value of this innovation? Or do we just want to wait for the bodies to pile up and do it when we have no other choice? There's no doubt in my mind we're going to have to do it, and we're going to look back on it and as the right thing and the only thing we could have done.
You say who you represent. I mean, do you get a sense that there are many of you who are either in alliances, associations, kind of coming together and thinking, actually, get a grip, your commission and policymakers? Is there a sense of a community coming together? Because what you're saying is, and adversity, there's nothing like adversity being the mother of invention, and we can't always live our lives like that. Otherwise, it's just crazy, right? That there has to be something that, what you're saying, you're absolutely right. But how does the industry and the profession organize itself in the classic kind of community organization way, saying we need change at the European level?
Well, I see this as a continuation of a conversation we've been having for years and years. In Europe, we've been talking a very long time about lack of efficiencies in the healthcare system, ways to get around that by, partnering, healthcare systems and private sector to help take some of the drudgery out of clinicians and nurses' work so they can spend the time doing what they're supposed to do, which is spend time with patients. Some hospitals here and there piloted it, but it didn't really take off. And now what we're just seeing with this healthcare worker shortage is just a continuation and an exacerbation of something we were allowing to fester and grow. So for me, again, it's just we're maturing through that discussion and we're getting closer to the point where we have to do this and have to do the thing that was always an option in front of us. So for me, I'm very sympathetic to all the remarks about what the constraints are. I do agree with MEP Sokol. It needs to be embraced at a certain point in time by member states, maybe not all, but one or two who are willing to actually try to do something different. And I'm sure that example of them having the courage to try and making it worse will inspire the others.
Okay. Kind of gradual peer pressure
If you
type
ask
thing.
me in wintertime, maybe I'll be less optimistic.
Precisely. Yeah. That's what I mean. Adversity is the mother of invention sometimes. Gentleman there, and some of the women in the room, please also contribute. Thank you.
Hi, I'm Peter Polborg from DG Santé. 2 words, basically. First of all, I think that there's a big change in the way that the Commission is interacting with the Member States, and also the Member States are interacting with the Commission. I've been since 2012 in DG Santé, and already I can see a shift, a change, especially since the technical support instrument came into force. Before the TSI, DG Santé and the Commission in general used to be very cautious when interacting with the Member States because of that infamous sub-Article 7 of Article 168, which states that the competence in the governance and management of the health system lies in the Member State. So basically, the Commission always was a bit cautious, and the Member States were very jealous to protect this. Came into play the technical support instrument, and now, some time ago, it was the technical support, structural support system, whatever. And slowly, the Member States started asking for technical support from the Commission, which was an interesting development. We always used to, I monitor health systems, and you realize that some Member States are really in need of assistance, and they are happy to receive it. Yet there was no proper way of doing this. Slowly, all the Member States came on board, and now even Germany and France and Denmark and whatever country are taking part in this technical assistance program. But what's very interesting about the program is that it's not only just because it's totally free on the Member State, but it's a very good way for Member States to cooperate and come together and exchange experiences. Eleni said that there are pockets in innovations, and basically, I think many of the health systems have pockets where they are doing something good. The unfortunate thing is how to actually make it happen in the whole system. That's, I think, is very, very difficult. Obviously, the innovation will help, but I remember the introduction of laparoscopy. I remember our surgeons were, not all of them obviously, were really resisting the change, because whereas before they were working like this, now they have to work
like that, absolutely.
because they're looking at the screen and they're maneuvering levers. So obviously, it was difficult for some, and it was very challenging to make the change. But now we take laparoscopy for granted. And I think that was the first real change that I saw in my career as a medical professional.
Yeah.
That really made the difference in the...
But it took a decade, no? Would you say, or longer than that?
It was around 80s.
So, okay. I don't think we've got the time and the luxury for that kind of adaptation or adoption these days. But your point is well made, though. Your point is well made.
So basically, I think that innovation will come. It will face challenges, but definitely it's here to stay. So slowly, I think it will be embraced, and I think that it will benefit, the health system will benefit, as long as Natasha said, like Natasha said, we keep in our mind that in the end we're dealing with humans, and normally humans like to relate with other humans.
Sure.
We don't just take out the humans out of
No, indeed.
the equation.
It's about how do you reprocess the whole system to make it more efficient using technology appropriately and ethically. I suppose the only point about what you're saying to me is it feels like a good bedtime story to a child to say, good things will come, just be patient, and our time will come. And I feel, and that's not to be critical of you at all, it's just the sense that where do we get the momentum of urgency? Because if you speak to, we all have family and friends who are going into either primary health care or hospital care, and you see it is shocking. Absolutely shocking. That's why we call it, there's a crisis in the system that needs to be resolved. It's about how do you move in the direction rather than having... what worries us is that poor, and I mean materially poor people, will die unnecessarily, either inside the system or outside the system. And they're the ones who are least able to advocate for themselves and least materially wealthy to opt for different models, which all of us can take for granted. And I think that's what we need to do. Andrea, please.
Yeah, no, the only thing is I understand this concept of waiting. I was born impatient from day one, so there's I keep caring and dealing with it. But generally speaking, there is the pace of innovation, there is the pace of transformation, and in the middle, to your point, there are people. This means we accept that people die, is undertreated, kids with rare diseases don't receive the right cure, because one day will come. I think this is the political challenge that we have. If we realize what is at stake is not to have another better, nicer robot or a pill smaller than the one before. Instead, there is the life of people, the healthcare, health is wealth, WHO, we learn since many years. So there are several conditions. So intervening to accelerate the sense of urgency is to respond to this societal demand.
Andrea, whilst you've got the mic, and I'm going to ask each of you as we wrap up, because I'm conscious of the fact that numbers are dwindling and you've all got other meetings. It's great, I'm enjoying it, and I'm sure you are, but we've got other things to do, unfortunately. What would be your one demand of the Commission? When it's thinking about, because as I said earlier, this is the only mandate that has witnessed the crisis of health in a way, we've never done before. There hasn't been a single mandate ever in the past, since EU was created, that experienced this kind of health crisis. What would you say to them about what they need to do next year?
But they have a lot. At least they have to operate through the entire cycle. When I think to technologies and innovative technologies, they have tools that they have to reform immediately, the MDR, the pharma package and not focusing in that violent. I appreciate the patents, the issue, the incentive, but how you promote the innovation? Which are the mechanisms that you are putting there? No, this is the only, I'm addressing to the Commission, is the only area of the world where there is no, for medical devices and innovation, no breakthrough path. You have in Japan, you have in US, in Brazil they are putting, Anvisa, they are putting in Brazil. I respect the Brazil.
I like the way you say, even in Brazil.
No, but guys, we pretend to be one of the most innovative regions in the world, but results are not there. So it's this type of, they have the power to set laws and regulation, and this should be the enabler. So this is their goal. I'm not talking about countries will fund and other type of stuff, but that's really the great challenge that they have in front.
Because they can, that's the added value. I mean, when you think, the two examples you cite, when you think about the R&D spend as a proportion of GDP, Japan, US, other countries, far more, double percentages that are higher than the EU does. And actually what you're saying is spend to innovate, really, and you can do that. Thank you, Andrea. Francis.
I would ask them to work more on outcomes and accessibility. I mean, we speak a lot about GDP per capita and how much we spend on healthcare. I think we should work much more about what are the outcomes, the results we reach with what we spend, and also are we building healthcare system accessible for the population. Once you measure that, once you communicate that to the population, to the patients, then you can really act on building a new system.
Great, thank you. Eleni, last but not least.
Just 2 comments. One would be that, probably to the Commission, test before you ask, or before you regulate. Even the calls for funding in Horizon, for example, some of them have to be tested before they are called for people. They don't make sense sometimes. Sorry, not all of the time.
You regret speaking, don't you? But no, I'm glad you did. Go on.
No, the other thing is that I would go with Oliver. I'm optimistic as well. We have an aging population, but new people are aging as well, and they will become the aging population in a few years, and they will be digitally literate, much more than our generation, and they will be there to take up the innovation much better than this generation, both as a patient, as expert as well. I think the only way is to go forward with innovation and try to make it cheap, because that's the way to spread it to everybody.
Thank you very much. Thank you all three, and obviously Natasha. Really helpful. It's been, I know I have not ensured you interacted as much as possible, but it was such thoughtful contribution that we learned a lot, but also understood what the kind of issues are that we need to really be thinking about. Thank you for that. But I suppose what shouldn't be lost on us is the sense of urgency. I don't know how you make it happen, but I feel that, when we think about this panel, if you had these characters in a sandbox with commission folk, what magic could happen? But it's so easily done, but people don't do it. However, there you go. Thank you all for being here and being patient. And without you, obviously, this wouldn't be possible. So thank you very much, and thank you. And see you again soon. And have a lovely, safe summer. Let's hope you don't either get too wet or too hot. On that note, take care. Bye-bye. Thank you.